This surgical procedure will demonstrate a descemet stripping endothelial keratoplasty performed with the Endoglide ultra-thin donor inserter device. As you can see here, this patient has quite severe corneal decompensation with the presence of two glaucoma drainage devices, both superior nasal and superior temporal, and is also pseudophakic. The first stage would be to remove the corneal epithelium, which certainly helps to improve visualization, dries up the cornea, and one may begin to see the two tubes. One of them is a bit long and will need some trimming. After the epithelium is removed, for the wound, the calipers are marking out 4.5 millimeters on the peripheral cornea, and we're going to perform a scleral tunnel approach. Normally this is temporally sighted, but as you can see here, because there is a tube which is superior temporal, we've shifted the wound more inferiorly. The advantage of the Endoglide is that you can actually perform the surgery at quite different aspects of the cornea. A scleral tunnel wound is preferred because it adds increased stability of the wound structure and has got minimal refractive change. Firstly, a diamond is used to score the scleral area about 1 millimeter behind the limbus, and then a crescent blade is used to tunnel and create about a 2 millimeter long scleral tunnel, which measures, as I mentioned, 4.5 millimeters in width. The entry into the anterior chamber is going to be performed later. Next, an inferior paracentesis is performed for both the peripheral iridectomy, which is performed using the straight loading endoglide forceps, and also is the position of the anterior chamber or the AC maintainer. The scleral wound is then partially opened and the anterior chamber filled with a cohesive viscoelastic. A nasal paracentesis allows for introduction of the endoglide insertion forceps, which is now used to grasp the tube, which is going to be trimmed. And we trim this using a long diamond from the other end from the scleral tunnel side. This nasal paracentesis is also going to be used for donor pull-through. Next is the descemet stripping. This is performed under the viscoelastic, and initially a gentle scoring will allow us to separate descemes or to tear descemes membrane. Scoring is then performed all the way round, and the reverse Sinskey hook is used to strip descemes from the recipient cornea. Again, the endoglide insertion forceps is useful to also help you grasp the descemes membrane and remove it from the anterior chamber, as you can see here. The scleral wound is now open all the way to 4.5 millimeters, and we turn to the donor preparation. First, we are filling both the chamber and the preparation well of the endoglide device with BSS. Next, the pre-cut donor is placed on the Cornonet donor punch, stromal side up, and the first thing we do will be to mark the edges of the cap, the outer edges, with an ink marker, so that when we turn the donor tissue endothelial surface up, we can still see the peripheral edge of the stromal cap. This will aid in centration for the trephination of the donor. This is an ultra-thin donor which measures 86 microns, and the punch diameter is 8.5 millimeters. After trephining, we usually like to check the donor rim to make sure that the trephination has indeed occurred well within the circle of dots, which suggests a well-centered trephination. Next, we need to separate the edges of the anterior and posterior lenticles, and this is done manually with a BSS cannula as well as injecting BSS. For ultra-thin tissue, one has to be quite careful because, as you can see, the tissue is very likely to wrinkle up, and it's important not to damage the posterior lenticle at this stage. Once separation has been fully achieved, excess BSS is wicked off, and then using a pattern spatula, the donor with both anterior and posterior caps is then transferred directly to the well of the endoglide device. And careful removal of the anterior stromal cap is then performed. The donor is carefully nudged in towards the shoulders of the cartridge, and then using a dry Wexel sponge, fluid is wicked away from the front end of the chamber, and in so doing you will notice that the donor begins to coil inwards due to capillary forces, which will help in the coiling process. A small amount of viscoelastic is placed. The endoglide loading forceps is then used to grasp the leading edge of the donor and gently bring it into the chamber. You will notice the gentle side-to-side movements greatly helps in coiling this ultra-thin donor tissue without tissue distortion or wrinkling. The donor is pulled all the way to the front opening of the chamber and gently released. Note that there will usually be some degree of endothelium to endothelium contact or endothelium to stromal touch, but this will be minimal. Apposition of stroma to stroma contact may actually help in structurally supporting the coiling of very thin or ultra-thin grafts. Finally, the saddle may be removed and the back end of the inserter with the words loading uppermost is used to seal the back end, and there should be an audible click to seal the chamber. The inserter is now everted back to the anatomical position facing up, and one may inspect the donor, which is nicely coiled in this case. For donor insertion, the anterior glide portion of the endoglide device is first carefully passed through the scleral wound. At this point, the chamber is maintained with the AC maintainer on low flow, and the anterior glide portion of the device prevents iris prolapse as the device is passed through. Holding the lip of the wound, the entire endoglide chamber is then passed right into the eye, and through the nasal paracentesis, the insertion forceps is passed to grasp the leading edge of the donor, which is then pulled into the anterior chamber. Once the donor is in, then the glide is carefully removed, and the AC maintainer will deepen the chamber, and with a bit of gentle persuasion and wriggling movements, the donor can be seen to uncoil. Once the donor is uncoiled, whilst still holding on to the donor, a small amount of air is injected into the anterior chamber to float the donor up before one can then release the donor. For a 4.5 scleral wound, 2 sutures are usually enough to secure the wound. It's usually advisable to also suture the AC maintainer paracentesis site. With the donor well-centered, a 30-gauge needle is then used to inject air to create the air tamponade necessary to prevent dislocation. In this patient with 2 tubes, obviously there would be a higher risk of donor dislocation. We have 4 pre-placed venting incisions, and we will be using these to remove fluid. A slit lamp attachment prior to venting incision shows there are small gaps, or there is a small gap of fluid between the ultra-thin donor and the recipient cornea. And so here we're just milking some fluid out, fluid pockets between the donor and the stroma through the venting incisions. And once this is performed, we can go back and look under the slit lamp, and you'll see that the gaps are now gone. So this is a useful approach to reduce the risk of donor dislocation, especially in cases like glaucoma, where they have either blebs or drainage tubes in place. In this patient, we will keep a full airfill at the end of the procedure, just to reduce the rate of donor dislocation. One also has to look out for wrinkles in the donor, for very thin, ultra-thin donor tissues, and one may have to reposition the graft if necessary. Finally, conj closure is effected, and subconjunctival antibiotics and steroids are given, and a bandage lens is placed, signaling the end of this operation. Post-operatively, this patient did well. This is what the eye looked like on day 4, and there was no evidence of donor dislocation. Visual acuity at this stage was 20/80.